unexpected, and the number we do focus on is that rolling 7-day average. That is now 9,731, the first time it's been below 10,000 cases a day for quite some time. And a week ago it was 3,000 higher than that at 12,785. So saying, the seriousness of COVID-19, even the Omicron variant, remains clear. There are 622 people in hospital around the country, and of those 23 are in ICU or a high dependency unit. We're also today, sadly, reporting a further 16 deaths of people with COVID. So our total number of reported deaths is 516, and the 7-day rolling average is now 13. My sincere condolences as ever to whānau, friends and communities who have lost these treasured people. Once again, I've got a few slides to just help display the shape of the outbreak here. I think, here we go, I've got a little clicker here. So reassuringly, we are continuing to see the numbers of cases, as you know, drop, and this slide here shows the case rates per 1,000 people. Over the last week, that's fallen from 18.6 per 1,000 to 14.3 per 1,000, so that's a 23% drop. You can see regional variation there. The northern region now has the lowest case rate after reaching that quite high early peak, and in all the other regions it's slowly declining. But you can see it's only really this last 2 or 3 weeks where the case rates in all regions have started to decline, so really since that 27 March date. Overall, in just about every DHB, rates are coming down, certainly for all DHBs in the central region, of which Wellington is a part. In the northern region, we saw that early peak, and Northland was a bit slower to peak than the Metro Auckland District Health Boards, but is now trending downwards as well. In the southern region, all DHBs except the West Coast, the case rates rose through March and peaked in late March and have started to decline. The West Coast is much lower case numbers, but is still is yet to reach its peak. And likewise in the Te Manawataki region, which is centred around the Waikato and beyond, all those DHBs there, the case rates peaked around the 13th of March and have been steadily declining since. Tairāwhiti reached, of all our DHBs, the highest peak at approximately 45 cases per 1,000 at its peak. Taranaki DHB is a little slower than the others in that region to peak, but is now starting to trend downwards as well. Looking then at hospitalisation, this next graph shows us just what is happening with occupied bed numbers, and this is northern region, so it's the 3 Auckland Metro District Health Boards and Northland. You can see that, again, those hospitalised cases is coming down, but much slower than the case numbers. And we are seeing a drop in hospitalised cases right around the motu now in all our regions. Slide 3 actually shows new hospital admissions each day, and we can see that that is trending downwards as much more as we would expect. And so over the weekend, across Auckland, only about 20 cases a day of COVID or people with COVID being admitted to hospital. So it's good to see those new admissions coming down, but still that long tail of hospitalisations in the Auckland region. Just a reminder, there are 3 actions that everybody can undertake to help protect themselves from and others from COVID-19. The first, of course, is to be up to date with vaccinations, and that includes having a booster or completing your course if you haven't yet done so. Secondly, wear a mask. Masks are still required in many indoor settings, including at the moment in schools. A good rule of thumb is to always wear a mask indoors whenever you're not at home. And third, and very importantly, stay at home if you're unwell and avoid others, whether you have COVID or not. Of course, if you do have COVID, then you're still required to isolate for 7 days at home or in a safe place, as are your household contacts. Doing the basics well has served us incredibly well as a country to date and continues to be central to our response. I'd now like to hand over to Dr. Town. I'll then have a few closing comments and we'll be on for questions. Thanks.
Kia ora mai tātou, good afternoon, and thank you, Dr. Bloomfield. I'm going to speak a little bit about the research project that the Director General referred to and make some comments about the research and science contribution to the pandemic response around the world. Undeniably, the pandemic of COVID-19 in New Zealand has created unprecedented pressures on our public health system. But our continuous science and evidence-led response has been critical to our successes to date. The global science community has made a number of major contributions, including understanding complex details such as variants and whole genome sequencing, and more particularly the massive global effort to deliver safe and effective vaccines to the world. More recently, therapeutics have become a focus, and as you're aware and previously announced, we now have an oral antiviral agent, Paxlovid, available here in New Zealand. So as we think about the research and science effort, we look back but also use those learnings to look ahead and plan for future pandemics. In that vein, I'd like to update you about one of the important studies that we have already funded, the impacts of COVID-19 in Ayateora study, which is being conducted this year, started in February by colleagues working at Victoria University here in Wellington. The aim of the study is to understand the experiences of people in Aotearoa, New Zealand, who've had COVID-19. We want to know more about the impact it has had on their health and well-being of both themselves, but also their whānau and families. We hope that the outcomes of the study, when they're reported later this year, will help us be better prepared and also understand how to provide better support services for people with an illness such as COVID-19. So as previously noted, it is available to anyone in New Zealand who had COVID through until December 2021. So that's the cut-off date for participation. There'll be an online questionnaire for people to answer about their lived experience, and then with selected smaller groups in detail interviews and focus groups will be undertaken, including from a number of Māori participants, Pacifica participants, people with disability, and those who were infected with COVID-19 at work, including healthcare workers. So far, 400 people have completed the survey, and a similar number have engaged with the research team and are considering taking part. We'd like to encourage anyone who experienced COVID last year to consider taking part and to get in touch with the researchers. I'll just give you now the 0800 number, which is 0800 800 581. That's 0800 800 581. Or you can log into the website and express interest in participating. That website is www.covidayatearoa.com. That's www.covidayatearoa.com. Thinking more broadly about the science-led response, we have already funded a number of research projects, as well as the one I've just discussed. Last year, in partnership with the Health Research Council, we made available a $1 million pool of funding for rapid response research, and we were delighted when the Health Research Council also made available an additional $2 million under their COVID-19 Emerging Infectious Diseases grant program, which contributed more broadly to the all-of-government response. A number of these projects had a direct impact on our understanding of the disease and the response itself, including collaborative work between ESR and scientists at Victoria University to speed up whole genome sequence reporting in near real time, and this was an essential tool in the response last year. These techniques can also be applied to other viral infections, such as influenza, and should form one of the tools that we're able to use in the months ahead. Whole genome sequencing, as you recall, was pretty critical during that elimination phase when we were looking to see connections that were not only linked people between people, not only epidemiologically, but also by linking the whole genome sequence and any variations in that. One of the most high-profile studies was the one coordinated here in New Zealand by the Medical Research Institute of New Zealand. That REMAP-CAP COVID study, which has been reported widely, was one of the studies that found that dexamethasone, a widely used steroid pharmaceutical, was very beneficial for those in hospital with a deteriorating course with COVID-19 infection. Those findings directly informed the international protocols for the management of COVID-19 for those in hospital. So we've already experienced a number of benefits from locally funded research, and we're working with the Director General and colleagues to look at whether or not we can fund other research initiatives in the near future. One that's in advanced planning is a detailed case note review of all those people that were admitted to hospital with COVID-19 this year. And that will give us information to help us understand the course of hospital treatment and also plan protocols for the future. Thank you, and I'll hand you back to Dr. Bloomfield now.
Thanks very much, Ian. I'm pleased to say, as we prepare for winter, more than 230,000 people have already received a flu vaccination since the campaign kick-started on the 1st of April. As I've noted previously, a number of us are concerned about the potential impact of a flu outbreak on top of ongoing COVID infection. And that could, of course, add to the strain on the healthcare system, especially as we haven't had flu circulating for now 2 years. Flu vaccination is free for people at higher risk, and even if you haven't had a flu vaccination before, now is a good time and a good year to go and have your first one. I also want to re-emphasise the importance of MMR, measles, mumps, rubella vaccination. We had that measles outbreak in 2019, and it resulted in a number of children being in hospital very unwell. The MMR vaccine is effective and safe, and if you're between 16 and 32 and aren't sure if you've had 2 MMR vaccines, you can go along and get a free vaccine at any time, so please do that. We know that many children pick it up from it's circulating amongst young people. So important everyone goes into winter with as much protection as possible, including being up to date with COVID vaccines, having a flu vaccine, and of course MMR if you need one. Hoi anō, ka nui tēnā, kia ora koutou katoa. We're now happy to take questions.
Dr. Bloomfield, in relation to the person who had the third death linked to the COVID-19 vaccine, the ministry said that in the weeks prior to his death he received the dose. When prior to his death did he receive the Pfizer vaccine? If it's a male, I'm not sure of the general age of the individual.
I don't have the exact detail, but it was over a week. What I would say is, of course, this was a young person, a teenager, and very sad that this young person has died. The Independent Safety Monitoring Board has put a lot of thought and effort and work and consultation with the pathologist and the coroner in reaching its conclusions, and had quite a number of conversations with the family. And so we don't want to release any more detail about this, but the consensus was of the independent board that it's most likely this was vaccine related. We will never know. There is still some doubt. But one thing I do want to say is the family were very clear that they didn't want this death, this unfortunate and very sad death, to in any way put people off from being vaccinated or to be used by groups to try and undermine vaccination efforts in New Zealand.
Was the teenager seeking help for his heart inflammation myocarditis problem?
Actually, the death was quite sudden, and the person hadn't had any symptoms before the death.
Not even of the
The person hadn't had any symptoms.
On the back of that, obviously, we had a story on the project last night about a 35-year-old man who was ignored for months from New Zealand's health system with symptoms like myocarditis. Is New Zealand's health system taking vaccine injuries seriously?
Yes, and I read that story just before I came down because I was concerned about the experience of this man who had, as it transpired, sort of recurrent pericarditis and quite severe symptoms of that. From the very first time that we linked a myocarditis-related death to the vaccine, we put out quite comprehensive information to our health professionals around the country and all our vaccinators. And you will probably know that when you went for at least your second vaccination, that there was specific conversation about this being a potential side effect of a rare but potential side effect of the Pfizer vaccine. So we have very good information that is widespread through the system, and I think this man had a very unfortunate experience because, again, and Ian might want to comment on this, there is both myocarditis, which is rare but more common than the pericarditis, which is inflammation of the membrane around the heart. And I think it was unfortunate that he had this experience where his symptoms were not diagnosed and the possible link to the vaccine wasn't diagnosed. It's quite clear that there is now an understanding of that, and I hope that his experience is a lot better now.
Right, so you're hoping that will kind of streamline their experiences maybe for people who may have symptoms like this in the future?
Exactly, it's a learning experience. And what I would say is I know a number of clinicians around the country have been seeing people with these symptoms post, and in fact, there's my understanding is there's a quite high level of awareness of symptoms that might be chest pain or other related symptoms that people might be concerned about are related to the Pfizer vaccine, and people are seeking help. Yes.
And you've obviously put the public call out for people to get involved in this new study, people who transmitted COVID-19 throughout the pandemic. What do you hope you'll gain from this research, and what will the ministry do
Yeah.
to with this finding?
Yeah, so we chose this group because the research group, because they've got a lot of experience at understanding the lived experience of particular illnesses. They also have really good connections with Māori and Pacific researchers and Māori and Pacific communities. So one of the reasons we selected them was they could take a really broad view of different parts of New Zealand, different experiences from different community groups, and help us fine-tune future responses. Obviously, things have at times happened in a hurry. Like in future pandemics, if there are going to be them, for us to have our health system tuned up and understand the different needs of communities throughout the motu.
When do you expect the study to be wrapped up?
Well, we'll be enrolling people through till the end of May. At that point, we hope we'll have a good cohort of over 1,000 people. At that point, we'll then complete the interviews and start those in-depth focus groups with the smaller communities. And the results should be available in the early part of next year. So there's quite a big analysis and write-up period that occurs towards the end of this calendar year.
Why does the study only include people up to December last year?
Even in the latter part of last year, the numbers, of course, grew with the Delta outbreak, and there's a limit to how many people can be included, particularly in those detailed reviews. Where if we are able to conduct more research in the year ahead, then we'd like to look in more detail, as I mentioned, the hospital patients through the Omicron outbreak, and it may be possible to have a more inclusive survey of a wider community group, that we haven't got to the planning stage of that at this stage.
For the winter 2022 flu season, what, if any, sort of modelling has been done around how many people are expected to get ill and also how many are expected to be hospitalised or critically ill?
It's always good to hand the modelling questions over to someone else. I've just seen some initial modelling, but actually done by Dr. Gary Jackson, whose team does these graphs as well. At the moment, it's hard to know what will happen, but what they have done is just done some modelling, or they're doing some modelling to show what would happen if we had coincidental sort of an Omicron surge, an RSV outbreak, which mostly affects children, and a flu outbreak, and then what impact that would have on both our community and primary care services, but also our hospital. And of course, what we're trying to do is get a sense of what we can expect flu-wise by looking at the Northern Hemisphere. Two interesting things from the Northern Hemisphere flu season. First of all, a lot of the flu there was the type A rather than type B flu, and the variant they had in the vaccine up there, that the vaccine covered, didn't really provide much protection against that type A flu that they saw. The Southern Hemisphere vaccine's got a different makeup to it, so a different influenza type A sort of protection in it, which is good. The second thing is the season there is quite late. Now, that may mean that there are more people with flu as our borders open, which could mean we have more, a higher risk of it coming across the borders. One of the good things is, though, that we will probably see that happening with it appearing in Australia, possibly Singapore and some other countries, so that will give us a bit of a warning. In the meantime, we do know that we've got a good vaccine for this year, and if we can get as many people vaccinated as possible, that will help a lot.
How many New Zealanders currently have no immunity to influenza at all?
Well, previous vaccines and influenza infection do provide some residual immunity. It just depends on what the circulating subtypes are. And this is probably your specialist area as you're a respiratory physician. You can correct me if I'm wrong. We've seen that in the past. But the key point is that the subtypes change a little each year. And given we've had 2 years without any exposure to the subtypes, that could mean that there is a lower level of immunity than we would usually see. So saying, so far, the experience of influenza-like illness symptoms in the community, even with an Omicron outbreak, has been lower than in an average flu year at this time of year. So that's a good sign.
Is that due to lack of travel crossing international borders?
It probably is, yes.
Yep. What work are you doing on the XE variant, and if and when it arrives, what would our response look like?
Well, at the moment, we're making sure that we've got surveillance in place and are doing whole genome sequencing on our border-related cases. ESR so far has not seen any of the XE variant here. I think Australia's found a small number of the samples it's sequenced have been the XE variant. And really, we're looking just to see what impact it's having in other countries at this point in time. But the sort of increased transmissibility over the BA2 variant is pretty modest, estimates 5 to 10%. The other thing I would say is that if we look at the UK at the moment, 88% of its sequenced variants at the moment are the BA2 variant, which is almost the same here. We're 86% in the latest ESR report. So we're not seeing that XE variant sort of start to overtake the BA2 variant in the UK at the moment.
How would you best describe the XE variant compared to previous variants that we've had here? People at home that just don't really understand what it is.
Well, what I would say is it's more similar to the BA2 variant, which is the one that is causing most of our infections here in Aotearoa. It's more similar to that than the BA2 variant is to the BA1 variant, subvariant, and way more similar to that than it is to the Delta variant. So it's only a sort of a marginal change in terms of its infectiousness and what we know about its severity compared with the variant we've already got here. So the key thing is if people do what they're doing now, as I said, vaccination, using a mask, staying home when you're unwell, those will be the best things, even if we do get the XE variant here.
So from what you know, New Zealand's response could very much be what it is now?
Based on what we know to date, yes. Of course, what we're also looking out for is the emergence of any other variants of concern. And Ian, I wonder, you might want to talk about the different, I'm putting them on the spot here, some of the different scenarios that we're looking at for potential new variants of concern.
Yes, thank you, Ashley. So yes, the Minister Verrill has commissioned some work looking at the future in the months and year ahead beyond winter to start to understand what some of the potential outcomes of a new variant might be. Be they more infectious, which of course is the BA2 experience, isn't it? We're highly infectious, more so than Delta and previous variants. And then that balanced off with the disease severity. So what is the impact on the individual when they become infected? Does it get into the lungs more quickly? Is it more likely to lead to hospital admission? So those are sort of balancing questions, and in that evolutionary kind of tie-up that we've discussed before, there's always a trade-off at that viral level between how infectious it is and how severe it is. And obviously this infectious BA2 variant has proved very adaptive and is being spread very rapidly. So Minister Verrill has asked us to start thinking about a matrix where we're looking at some of these variables, looking at the actual genomic change that occurs mainly in that spike protein, and then looking at how that would play out in terms of the behaviour and the activity of the virus itself. So that work will take us the next 3 or 4 weeks, and we'll be moving through a number of scenarios and then as Dr. Bloomfield has mentioned, looking at the way in which we'd be responding to those types of new variants should they occur. The key thing is we'll probably see overseas the emergence of these and hopefully detect them quickly at the border should they arrive here in New Zealand.
What's the worst case scenario?
Well, there's something I've seen written up called the Doomsday Scenario, so we really hope that doesn't occur. I think the key thing is that there's always a trade-off in terms of the virus. Obviously, in the extreme example, if everyone that contracts the virus has a fatal outcome, the virus will not be able to persist in wider society. So we're imagining from our genomic specialists that actually it's that infectious thing that makes it have an advantage. And so we're kind of looking at that milder end of the spectrum in terms of the scenarios, but there's always that balance there. So we'll do a number of different scenarios and see where that takes us in terms of planning.
Right, so could you match different responses to different scenarios that
Yeah.
you come up with?
Yeah, that's the idea. Obviously, if it is more and more infectious, we have to look at those public health control measures which stop it from spreading from one person to another.
There's been an increase in Fiji this week of apparent dengue fever and leptospirosis cases. What are the chances, particularly as borders open up, of those illnesses spreading here? And also, what, if anything, is New Zealand doing to help Fiji with this upsurge in their health problems?
Not on top of that, I must ask the Director General to answer that one.
I dare say I'm not on top of it either. Dengue's always a risk in a number of Pacific countries, and I think anyone travelling there, and I imagine there are a lot of people planning either over this next couple of weeks or ahead to winter to get some sun in the Pacific, and that's a great idea. But the usual precautions around avoiding getting dengue, so that's, of course, protection against being bitten by mosquitoes. We're not generally asked to help out, certainly not with Fiji if they have outbreaks of dengue or leptospirosis. But of course, as we have done with COVID, we're always prepared to help if asked.
Dr. Bloomfield, with the review of the traffic light settings coming up, what do you need to see for places to go to orange?
The criteria that the team has assessed against are very clearly laid out, including by Cabinet. And so they did that assessment yesterday. I've provided the advice through, and Minister Hipkins will make an announcement tomorrow on what the decision is by ministers with power to act based on, largely, I think, on the advice we've given. So I won't preempt what that decision will be. Any final questions?
How concerned are you about how our ICUs will cope over winter when surgical capacity nurses aren't available because they're needed on wards or other parts of the hospital?
Well, we've obviously had some experience of this through the Omicron outbreak. And I think, that the planning that our hospitals did paid off because it meant they were able to deploy staff to those areas where they were most needed. And we have got those surge nursing staff that are trained to help out, to give care to people who might need a high level of care, including intensive care. So I think I'm more concerned about the pressure right across the system, including in primary and community care. And I want to reiterate that point. Only about 0.5% of our cases in this Omicron outbreak have ended up in hospital. So most of the pressure has really been out in general practice and primary care and community care. And so that, they've had a lot of extra visits and they've been managing that really well on top of their usual workload.
Just as a follow-up to that, nurses say they're nervous about an exodus of staff as soon as the borders open, and just to accommodate people wanting to use up leave. Have you provided any advice to the HBs on how to manage this?
We're certainly working closely with them. I think they're all too aware of not just the potential for people to go overseas, not just in the health sector but elsewhere. And also there are a number of our members of our health workforce whose whānau live overseas and they may well be wanting to visit them. So these are some of the things we're factoring into the planning for this winter, alongside that potential for the sort of influenza and COVID outbreaks at the same time. I think DHBs are all too aware of it. Yep.
And lastly, what do you make of the small group of protesters outside the Ministry of Health?
Well, I haven't seen them yet, but if it's a small group, I mean, that's fine. And of course, people have got a range of views they might want to express. I've been incredibly heartened throughout the pandemic by the level of support that the vast majority of New Zealanders have provided for our efforts. And I was reminded of these just last week when I received a number of very good messages, as did Dr. McElnay before she left, some very kind messages from a whole range of people thanking her in particular for her amazing service and role she had played as the Director of Public Health. Any final questions? If not, thank you very much. Really appreciate you coming up the road, and enjoy the rest of the day. Kia ora.
You're done.